on your screen. You don't have that, physically wave. And if you have a total technology meltdown and you end up getting bounced out, I've got my email set up in front of me. So drop me an email at jhaldon@thurrock.gov.uk if there is a question you're trying to get out and for whatever reason you can't. This is my first meeting chairing the board as the portfolio holder for social care. I just wanted to take a couple of moments and thank staff from all of your different organisations for what they have done during the course of the pandemic. Everyone from acute hospitals, Andrew Pike, who was an absolute Trojan and managed to get the art of briefing and the activities of an entire acute hospital down to a brisk 3 minutes for me. All the foster carers that I've met digitally, the care leavers who have digitally shown me around their homes, the social workers I have met who have given me a tour of older people facilities. I'd like to thank our CCG and our third sector who, genuinely heartwarming when the CCG and CVS are telling us we've actually got, at the start of the outbreak, 2 million volunteers for functions at that stage. That's very heartwarming. And I'd also like to put on record my own thanks to my own officers, Roger Harris, Ian Wake, Sheila Murphy, who I've always been aware I'm quite lucky to be the portfolio holder for substantially cleverer people than I am. But certainly during the period of this crisis, the energy they displayed was absolutely remarkable. And also special thanks to Darren as always being a fantastic business manager for this board. Obviously, we're going to have very substantially difficult times ahead. COVID has created a £9 million pressure in the capital this year alone. I think all colleagues in social care would say that COVID, by no stretch of the imagination, is done for us yet. Even though the country is unlocking, social care is still very much in COVID response. And on top of all of that, we now have a pretty serious recession we're looking at. But there are areas in which we can say we are fortunate. Our financial resilience does mean we can keep Oak House for the next 12 months to provide that additional resource going into the winter. We have got superbly strong relationships across partners in Thurrock, and that's something we're hoping to build on as we hold a post-COVID learning summit later this year. And the family locally is growing. We're very lucky to have Mark Tebbs as our new CCG interim chief. Mark's been with the CCG for a number of years and is a firm friend. We're very lucky that we've had Anthony McKeever, who has supplied fantastic leadership during this period. And we're very lucky to have Dr. Khalil as our new CCG chair. I've had the opportunity to meet with Dr. Khalil twice over the phone, and the new energy he brings, we're very, very lucky for. I'll also welcome Councillor Mays as the Portfolio Health, Sheila Murphy to our first meeting as the Corporate Director. If I've missed anyone else, I do apologise. We have had apologies from Michelle Stapleton, Andy Millard. I have on my list Julie Rogers, but I think I've seen her on the call.
Yes, I am, Chair.
Morning, Julie. Right, moving on to agenda item 2. Does anyone have any comments on the minutes from the 31st of January? Okay, well, we'll take those as written. Item 3, urgent items. I have not agreed to the consideration of any urgent items. Item 4, declarations of interest. Would anyone like to declare that they are interested? I'm taking notes of who isn't smiling at my little quips. And for those who actually work for the council, there will be redress later. Right, moving swiftly on to item 5, the annual report of the Director of Public Health on violence and vulnerability. Ian, would you like to lead off?
Thank you, Chair. It's a incredibly detailed and in-depth report, perhaps the most in-depth piece of work I think I've ever done. So I've got a PowerPoint. It's hopefully not too long, but just to pick out some of the salient points. So I won't share my screen. I'll try and present that now. Okay, can you all see that? Yep.
Yeah.
Super. Okay, so APHR 2019-20 was on youth violence and vulnerability. So I just wanted to pick out a few things today. Firstly, the public health approach to violence and what it is, because you might ask what on earth has youth violence got to do with public health. The scope of the report, some trends in youth violence, and some risk factors and causal factors in terms of the vulnerabilities, what works, what have we got and what's missing, and what needs to change. Okay, so the World Health Organization definition of a public health approach to violence is on the left-hand side of your screen. I won't read it. Public health approach to violence does a few things. Firstly, it conceptualizes violence as a communicable disease. Now, as you're aware, we're pretty preoccupied with another communicable disease at the moment, but you might ask, what has youth violence got to do with COVID-19? Well, in some senses, it does have some similarities. So violence, like COVID, starts with a single person and generally infects others in the community. It spreads out. It can be treated with interventions, and it can be controlled and prevented as well through inoculated, in inverted commas, others, through strengthening community resilience and reducing risks. Public health approach to violence also requires a whole systems approach, so it recognises this is a complex and multifactorial issue. No one intervention or no one magic silver bullet is going to solve this. It needs a whole range of different approaches and different organisations working together. And it uses data and intelligence and surveillance, again, in the same way that we'd use surveillance for a communicable disease, to try and understand the problem and to target interventions at where the issues are. It has 4 steps, so that's surveillance to start with, identifying the risk and protective factors, developing and evaluating interventions, and then implementation. And I hope that the report does at least the first 2 steps, maybe the first 3 steps, and what we now need to do is to implement. So starting just with some of the data on violence, there's a huge amount, as I say, in the report. I mean, the first thing to say is that actually violent crime, crime in general, if you exclude violent crime, has fallen since 2003, actually quite substantially, both in England and in Essex, Thurrock and Southend-on-Sea. Slight uptick after about 2015. But when you look at violence and violent crime, it tends to do the reverse. So you get quite a significant increase over the last 5 or so years. If we focus down over the last 4 years and look at offences in young people, so on the left you've got weapons offences and violence with injury for young people aged 10 to 24, Thurrock. On the right, the same, but for Greater Essex. So we can see here that we get a peak actually in both areas in 2016-17, and then it has started to fall off slightly, which is good news. We did some comparative analysis between district and boroughs across the county. So you can see Thurrock in the red for this is reported violent offences where the victim's aged 10 to 24, and on the right you've got the same but for weapons offences. So Thurrock's kind of in the middle of the pack in terms of absolute numbers. What we do know is that young people aren't equally distributed across the borough. So when you calculate it as a rate of young people aged 10 to 24, you find we actually don't do as well. So second highest rate in terms of violence with injury offences, and about the fourth highest rate for possession of weapons offences. One of the, I think, really stark findings of the report is that youth violence is still highly concentrated in a small geographical area. So we did a huge amount of analyses at ward level. So of the 665 wards in Essex, only 237, or just under 36%, had one or more violent incidents reported in the last 2 years. And you can see the distribution there with the Thurrock wards highlighted. If we zoom in on that data, if you're looking at wards, this is over the last 2 years now, we did at ward level, at 16 or more, you find that's only 2.4% of wards. And again, this kind of fits with the communicable disease analogy, that you tend to get it concentrating in a small number of places and then spreading out. I think you can demonstrate this really well, actually, if you look at Thurrock data on gangs. So the little red, I think they're red dots, I'm colourblind, with the red or green dots. This is 2016-17 data that's held by our youth offending service. Those are the approximate addresses of all the known gang nominals in Thurrock in 2016-17. If you fast forward 2 years, what you see is this. So again, you can see that problem spreading out in those areas. What we see if you look at 3 years data, so I plotted 3 years, so 16, 17, 17, 18, 18, 19 on this graph. Obviously, the numbers are going up, so the green is the latest data. But what you can also see is that the age in which certainly we're becoming aware that young people are entering gangs is also becoming younger. So in 16-17, the peak was about 19-20. That's dropped back a year by 2018-19. We also know that in terms, excuse me, of both weapons offences and gangs, that certain, or the BAME community is overrepresented. So for both violence against the person offences and weapons offences from our youth offending data, though interestingly not common assault. I don't have an explanation for this. I think this requires further investigation. The reasons are likely to be complex and multifactorial. You can see that really quite starkly with the gangs data, although interestingly, the proportion of Thurrock young people who are white who are becoming involved in gangs looks like it's increasing. If we are wanting to have a conversation, which I think we must, about structural inequality and inequalities affecting BME populations, this is clearly something we've got to look at, because if a young person becomes involved in a gang, that is a disaster for them in terms of their life opportunities. Very, very stark when you look at Class A drug supply, but the numbers are quite small on this. We looked at offenders to offences in terms of the YOS cohort. So 226 offences committed by 182 offenders when we look at violence against a person plus robbery. One of the really good things in this data is the vast majority of people who are accessing YOS because they've committed one of these offences don't seem to offend again. So there's only, each one of these little black bars is one offender. The vast majority of offenders only commit one offence. But at the right-hand side of the screen, you can see we've got this cohort of prolific offenders that, for whatever reason, the interventions through YOS are not working. And again, I think this warrants further investigation into what, if anything, we can do differently to intervene in the lives of these young people. So moving on to some of the vulnerabilities, there's a huge amount in the report about risk factors and protective factors. So for serious youth violence, you can categorise the risk factors into 5 categories: individual, family, school, peer group and community. The evidence base suggests that the strongest risk factors are actually focused on the individual. And the other thing about risk factors is they become risk factors at different ages. So the ones that are in bold are the ones that have the strongest evidence base. So you've got, in terms of individual troublesome, previously committed offences, high levels of daring, aggression, attitude to delinquency, running away and truancy, antisocial behaviour, substance misuse, gang membership, low self-esteem, and high psychopathic features. In terms of family, key ones are disrupted family and poor family supervision. In terms of school, low commitment to school. Peer group, about having relationships with delinquent peers or just poor relationships in general. And on the community ones, actually less strong, but it's about the culture of the community and community norms and values that accept and normalise violence, sufficient infrastructure, neighbourhood disorganisation. Moving on to gang involvement, they're generally the same, I have to say. Drug use at individual level features a bit higher, but generally the same risk factors. This I thought was really interesting. So as I'm sure many colleagues are aware, deprivation is generally a really good predictor of a whole range of health problems and public health issues and lifestyle issues. For violent crime, it's not. So I looked at the little blue dots are wards in Essex, and I looked at just about every single measure of deprivation I could find, and there really is no correlation. So how deprived the ward is doesn't predict really at all how violent, in terms of youth violence, it is likely to be. And that actually fits with the national evidence base as well. So this really interested me. So I really dug into this, and I came across this concept called the crime paradox. So what is the crime paradox? Well, the crime paradox has been known for many decades, and what it says is this. If you were to go into a young offenders institution, if you were to survey our cohort of young people accessing yachts, if you were going to go into a prison, you would find that the vast majority of the people in those institutions have come from some level of troubled or deprived background. But equally, if you survey the population who are deprived, who are living in deprived areas, what you will also find is that the vast majority of them never ever go on to commit a crime. And this is the crime paradox. And there's a really good study, the Peterborough longitudinal study undertaken by Cambridge University, that seeks to explore this in more detail. So the Peterborough study, it took a random sample of 716 young people, and it followed them from age 12 in 2002 through to early adolescence in 2015. The outcome variable it was looking at was actually not violent offences, but prolific offences. And it defined prolific offenders as those who, during that time period, committed 100 or more offences. So the first thing the Peterborough study found was, again, deprivation itself was a very poor predictor of who was going to become a prolific offender. So you've got deprivation on the x-axis and then crime frequency on the y. And so here we have the crime paradox. So you've got your cohort of 716 young people. The dark blue is the 40 who come from the most deprived or disadvantaged backgrounds, and the red circle is these persistent offenders. So you see that the vast majority of persistent offenders come from a deprived background, though not all of them, but the vast majority of young people who come from a deprived background are not persistent offenders. And what the Peterborough study tried to answer is what were the common factors in this persistent offenders group that were not common in the group that didn't offend, in both deprived and less deprived young people. And they found two key causal variables, and each causal variable had two subvariables. So the first causal variable they described as being exposed to a criminogenic environment. And the two subvariables in that were unstructured, unsupervised time spent in city centre locations with poor community cohesion and lack of social positive values. That's very kind of social science speak, isn't it? But I guess in layman's time, young people spent a lot of time knocking around with their mates unsupervised in areas that were perhaps not great. And the second was having peers who have an existing propensity to crime. So crime involved peers already. The second causal variable was developing an individual crime propensity. Again, two subvariables, low scores on a personal morality inventory and low scores on a self-control inventory. And actually, if you look at those risk factors, because having a risk factor is not necessarily the same as having a causal variable, but you can see that those risk factors map quite nicely onto those kind of four causal variables. But we wanted to really explain we'll explore what was going on with our young people in Thurrock. And we're really blessed in Thurrock in having Zantura, which is a hugely rich source of data. So all of those data sets on the left-hand side of the screen are in Zantura and linked. So we work with Zantura to undertake some quite detailed analyses on that data set. One of the really exciting things about Zantura is you can do category analysis. So on your field, you can count how many fields are filled in that have risk factors. But you can also do textual analysis. So a lot of social workers, for example, actually just write their free text. The problem, they don't fill in the categories because they're time poor. But Zantura can use that textual analysis to actually generate more categories and count more things. We looked at three outcome variables. The first was young people who are accessing YOS because they've committed a violent against a person offence. Second was gang membership, and the third was Class A drug supply. The data wasn't large enough, the data set wasn't large enough to do any statistical analysis that had any validity on the second two. So we ended up just concentrating on the first one, which was these violence against the person offences. And we did three sets of analysis. We looked at existing vulnerabilities, correlation of outcome over time, and predictive risk. And I'll just talk briefly about each. So the first one, which is existing vulnerabilities, that what we said is, of those young people, that cohort that are accessing YOS because they've committed a violence against a person offence, what risk factors did they have in their lives? So here you can see for age 10 to 14, the most common one was availability or exposure to drugs in the neighbourhood. Rather than drug use itself, it's this kind of neighbourhood disorganisation. Second was family violence. Third, substance misuse. Fourth and fifth, kind of school truancy or detachment. And sixth, actually. And then some individual ones, which were perhaps lower. When you look at the older age group of young people who access YOS because of violence against person offences, school exclusion becomes much more common. Availability of drugs, exposure in the neighbourhood was second, and truancy and low school commitment third. But the thing to bear in mind with this is it doesn't prove any causality, because what we don't know is what happened to the young people who are excluded or expelled from school but didn't commit violence against a person. So we're kind of looking back in the wrong way. The second element was correlation over time. So what this does is it says when you get spikes in young people, or numbers of young people who are committing violence against person offences, is there any correlation in spikes with some of the other risk variables? So a correlation of 0.5 or more we thought was significant. And what you see here is kind of 5 categories. You have this detachment from education again, drugs, but especially again at neighbourhood level rather than individual drug use, previous criminal history and exposure, family dysfunction, and some of the individual cognitive and behavioural things like conduct disorders, troublesome hyperactivity. And the third element was predictive analysis. I think this is probably the strongest in terms of the evidence base. So what this does is it takes 4 cohorts of young people. So it compares the numbers of young people with the risk factor or the vulnerability who did commit violence against the person and did not, and the numbers of young people without the risk factor who did and did not commit violence against a person. There does some clever statistics and calculates what's called an odds ratio. And what an odds ratio tells you is how much more likely someone with the risk factor is to commit violence against a person compared to someone without the risk factor. So we can see, for example, if you are excluded from school in Thurrock, in terms of our own data, you're almost 5 times more likely to commit violence against a person compared to someone who isn't excluded from school. So here, again, same 5 categories of variables. So detachment from education, drugs, but particularly at neighbourhood level, very, very strong predictor. Previous criminal history or exposure, family dysfunction, and those individual and cognitive. And if you think of those 5 Thurrock, what I think are the causal or the associated variables, they map actually quite nicely onto the Peterborough study, causal variables. You can explain all of the Peterborough study causal variables by looking at these 5. Just to focus in, because I think this is really important, this is so in terms of that school exclusion one, so we looked at quite detailed data on this for Thurrock. So when you compare Thurrock to other local authorities, so this is fixed term primary, we're above average but not greatly so. When you look at primary permanent exclusions, we're actually in the worst quartile. So I don't know what's going on here, but again, I think this requires further investigation. Conversely, at secondary school, fixed term, we do really, really well. We're the 3rd best in the country, and about average for permanent. When you take this down to school level, and we did this over 3 years to try and get a larger data set, you see quite a large variation between the exclusion rates, both permanent and temporary, at school level. So there's primary school, here's secondary school. And just the other thing that I think is really important, when you look at our PRU and you look at fixed term exclusions, you find the rate is enormous. And this really, really worries me, because these are likely to be already very, very vulnerable young people. And excluding them even for a short amount of time, I think makes them at really great risk of being groomed by gangs, entering county lines. So again, I think this needs further investigation. How do we respond to all this? Again, a huge amount in the report in terms of what works on the evidence base. You can categorise the interventions into, I think, 4 things. Universal, so the whole population gets them. Selective, which is essentially only at-risk populations get them. Targeted, which is about at-risk individuals getting them. And specialist, which is about when you've actually got people who have been exposed to violence or are committing violence, how do you treat them, if you want to go back to the communicable disease analogy. You can categorise the types of intervention into 8 categories. So promoting family environments that support healthy development, providing really good quality education early in life, the youth skills agenda. So this is more aimed in classrooms, I think, at young people at schools, but how can we improve and increase and teach them skills in communication, in empathy, in problem solving, conflict resolution and emotional intelligence. Connecting youth and adults and activity that role model positive behaviour. So I think 2 things here. The kind of traditional youth service offer, so out of schools activities and the youth service, and mentoring as well. There's a range of things you can do on wider determinants in terms of the built environment, in terms of social media, in terms of reducing the concentration of retail outlets that sell alcohol. And then as you move kind of towards the treatment and the other end of the scale, there's some really good evidence-based stuff you can do around early intervention for people who've been exposed or are showing high risk of violent behaviours. The evidence-based on preventing gang membership, I think, is very weak. Gang injunctions is about the only thing that has really strong evidence base. And in terms of law enforcement, again, there is some good evidence base about stop and search, but only where it's very highly targeted. If you look at what we're doing against this, so the green is where we're doing everything that's evidence-based, and we've got enough of it. The yellow is where we're doing some of it, but we maybe don't have enough of it, and the red is where we've got gaps. So what you see is we're really, really good at the early years stuff. The brighter futures, the outcomes on brighter futures are astonishingly good on just about every key indicator. So that was really great to see. And at the other end of the scale, in terms of the gangs, in terms of enforcement, I can't find anything that we should be doing that we're not doing. Where we've got the gaps is kind of in the middle. So I think we've got gaps around the youth skills element, although I think the wellbeing teams have an opportunity to try and close that. In terms of the mentoring and in terms of the youth service, I think what we've got is incredibly good, but we just haven't got enough of it. Its reach is inadequate. It's not reaching enough young people. And I think there are some gaps in terms of wider determinants, which I'll come talk about in a minute. On the treatment side, we're doing some good stuff, but the HUMES offer actually isn't best evidence-based on some of this stuff. It's very, very individually focused rather than family-focused. So gaps in service provision, that youth skills offer in terms of breadth and reach. So I don't think there's a great deal of evidence that we have that in place or that many people are benefiting from it, but the wellbeing teams and schools will say there's an opportunity to change that. Our Inspire, our youth services work, I think we're doing everything that's evidence-based, but we're just not doing enough of it. Similarly, mentoring. On the built environment, I think we've got a really good regeneration planning program in Thurrock, but we're not linking it to the evidence base and the data around this issue. So it kind of sits in a silo on its own. I think there's opportunities to, particularly on regeneration, target it a bit better. Social media, a huge problem. I don't see that we've got a comprehensive strategic approach to trying to tackle this. And then finally, and this came up again and again when I went out to speak to people in terms of HUMES. People said that young people couldn't get into it, the bar was set too high, and it didn't integrate with other elements of what we do, our other assets. We kind of set separately. Just some other key findings. I think we've got a huge amount of data, but we haven't integrated all of it adequately. So we haven't got police data flowing into Zantura, and we really need that. Trying to get police data was really difficult in terms of this piece of work. We managed it eventually. We're not using the data we have in a systematic way. And I think there's an opportunity in terms of the work we started with Zantura to build a predictive analysis risk model, which will help us to do that. I'm not convinced we've got a strategic response to this. I think the elements of what we do sit a bit under Health and Wellbeing Board, a bit under the Community Safety Partnership. There isn't an overarching strategy, and we need to use this report to develop one. And that really needs to target as well on that geographic targeting some of the areas that already have high levels of violence. On an individual level, I don't think we share risk between agencies adequately enough. So I think different agencies are very well aware of the young people that concern them, but I can't see a systematic way in which we're bringing all of that intelligence together and creating a kind of place-based, locality-based risk profile. Where we are targeting our interventions, I think it's too far downstream. I don't think Thurrock is unusual in this. I think this is a national problem. But we generally set the threshold too high. We're too reactive. We're waiting until young people are accessing YOS because they've committed a violent crime before we're intervening. So there's a lack of that proactive approach to risk. Again, I coined this term interventionitis. I don't think Thurrock's unusual in this, but I think we've got oodles of interventions that maybe have value in themselves, but we don't have that whole systems approach yet. I'm not sure we're evaluating everything we do as well as we could. The focus is still very much on individuals rather on the system, and it just feels a bit siloed. So in terms of conclusions, recommendations, the report makes 33 recommendations based around 4 key areas. If we come back to the communicable disease analogy, in terms of surveillance, there's a huge opportunity to build on the integrated data work and produce a risk model, and then to use that to put in place a systemic surveillance process and to target geographies better. On the primary prevention, so inoculating the population, strengthening the underlying protective and risk factors, reducing risk factors, I think more in terms of youth service provision reach, definitely more in terms of mentoring. I think that's a really exciting agenda. And that skills-based offer in schools, I think, again, we need to develop through the wellbeing teams. I think where we've got the biggest opportunities are on this secondary prevention. So this cohort of young people that are not showing risk factors or not meeting the current threshold for intervention, but are at high risk of becoming involved in gangs, high risk of committing violent offences. So I think we could do much better on that proactive intelligence risk sharing between agencies, developing a locality-based risk profile, a strengthened assets-based approach, and that detachment from education issue worries me, particularly at primary, fixed term, and with the PRU. In terms of the treatment stuff, there's that prolific offenders cohort I highlighted earlier. We need to understand better. I think there's more we can do with UMES in terms of trauma-focused CBT and a more holistic treatment offered. And we need to mainstream the youth service provision in A&E. And just finally, on that secondary prevention, I have had a go at a starting point for a model. So I think we need to bring together regularly in 4 multidisciplinary panels, a whole range of different professionals. And the question for those panels ought to be, who are your 10 young people you are most concerned about? What are your concerns? And I think sharing that intelligence between those agencies at a locality level will allow us to create a really good understanding of place-based risk. We could potentially play, as I'm sure, a predictive risk model into that. From that, I think we can do 3 things. Obviously, where young people is meeting the threshold for a statutory care response, that needs to happen. But I think where they're not, 2 more things can happen. So that place-based risk profile could be used to start to drive both strategic and operational the risks for responses from other agencies, so police enforcement, state and management, schools behaviour management, regional planning, environmental and transport. And secondly, for this cohort, as I say, that don't meet the statutory threshold but are at risk of becoming gang involved or becoming involved in violent crime, could we take an approach, a kind of strengths-based approach, perhaps a local area coordination approach, but for children and young people, to really proactively engage with young people, so non-statutory, working on strength and assets, and about agreeing goals, connecting them with community assets, and brokering coordinated care from specialist agencies to fill the gap. And I'll just finish with this, which is a quote I came across whilst I was producing the report that kind of really rung true to me, and the need to take that whole systems approach and to think about the context of the young person in terms of their environment, rather than just in terms of their head. I'll stop there. Thank you.
Well, thank you very much, Ian, for an excellent presentation. Right, I'm going to work through my list of hands. So first up, Jane Foster-Taylor.
Hi, yeah, no, just to say, phenomenal piece of work, really, really great piece of work, Ian. Councillor Holden, I'm just wondering whether we could nominate, I know it's another piece of work, Ian, but it would be really good for it to go to the Violence and Vulnerability Strategic Executive Group, because we've done pieces of work around violence and vulnerability, looking at different models and different care, but I've been to a couple, but they've not been pitched in this way or with a solution, which is really great. I know there's a few members here. Julie Rogers is on that meeting as well, and there's a few of us, but it would be really great. It's obviously police-led, and they've got different bits of the information that you might be missing, and it's another layer to the jigsaw. So I think it would be fantastic if we could perhaps do that.
Are you talking about the Police and Crime Commissioners?
Police and Crime Commissioning, Violence and Vulnerability, yes.
So I
okay,
did.
I'll amend it if Ian's happy.
Yeah, by all means. I did present some of the early findings whilst we were producing this to the ops group that sits under that. But yeah, very happy to take them.
Okay, Sheila Murphy.
Really probably echoing some of what Jane has said. I think it's a fantastic piece of work, given us lots to think about, also some solutions. And I know that we are looking at those in different groups that we've got. But I think again, what you've raised in your report is we need to be more coordinated and probably, less silo based. So fantastic stuff there, and it's probably onus is on us to make it work and to make a difference. And I know that we've all welcomed this report and we want to do that.
Thank you.
Thank you. I haven't got any hands at the moment, so I'll ask a question. So if anyone wants to put up their hand, please do. Ian, I'm just wondering about data sharing with the police. I know that some schools and some partners have a few concerns about the Encompass project, where the police share data between themselves and schools regarding issues like domestic abuse. That data sharing is not always as seamless as it needs to be. What is data sharing with the police in our schools like at the moment, and are there any possible refinements that you think that we need? I'm
possibly not the best person to answer that, because I'm not clear what data is being shared between the police and schools. I don't know whether Sheila wants to come in. In terms of broader data sharing with the police, what we need to do is get the police data into Xantura. That's the best mechanism, I think, in terms of the predictive risk analysis. I don't think the police are in any way not supportive of that. We've just got to make it happen. Unfortunately, COVID happened just after I finished this report, but I will get round to facilitating that meeting.
I think, did I see, bear with me, did I see Kim James or Christina Jackson pop up somewhere?
Thank you, Chair. Yes, I was waving fanatically in the background. Great piece of work, Ian. I'm just thinking there's a lot of organisations in the voluntary sector that are funded by trust funders, such as Children in Need, etc., that will be completely excluded from this, that are doing mentoring work, youth work. And I think it's how do we build that relationship and trust with these groups to share their data and intelligence as well. So that was one question. And the other is on the social media. How do we use sort of social influencers more to be able to get messages across on social media?
Again, so on the first one, mentoring something I'm really keen on. I'm quite keen on the concept of positive deviance. So a positive deviant is someone who's against the odds, come from a huge amount of challenges, but has really achieved. And when you look at the evidence on positive deviance, what you generally find is the thing that's made a difference is they've had one or more adults in their lives that have really inspired them, and it doesn't necessarily matter who that is. But if we could create some type of mentoring revolution in Thurrock to really expand the reach of that, I think that could be just incredible for structural inequalities and assisting young people. So I'd be really keen to have a conversation with you outside this meeting to see how we could and better understand what else is happening in the third sector. In terms of social media, it's a really difficult one, and I don't have the answers to it, and there isn't a great amount of evidence base on what works. I think because it's generally a very new phenomenon, but there's no doubt that the gangs are using social media in terms of drill music to glamorize a lifestyle and to groom and to entrap and to promote this, and we need a strategic and systematic response to it. I feel we need a kind of a thorough strategy on social media and young people. And again, I'd be really keen to hear other views. And if you are aware, in terms of social influences that we could use, I think it's a great idea.
I think I've got Julie Rogers.
Thank you, Chair. I just wanted to let you know that the Violence and Vulnerability Unit are still planning to have their violence conference this year. and they're planning to do one in Thurrock, and by popular demand, Ian is going to be rolled out in the afternoon to present this paper again. Bless him, I've heard this several times, and he does an excellent job. In the morning, they're going to be talking about Essex messages and learnings, and then in the afternoon it will be Ian's presentation with an opportunity for people to sort of talk about it, bring together ideas and various other things. So as soon as I know the date of that, we'll let you know, so that can be circulated for Thurrock people to attend.
Thank you.
Tanya?
Yeah, I just wanted to add that there have been some areas that have been looking at local area coordination that Ian suggested, working with people similar to this, and certainly with care leavers as well, with huge success. So it's certainly something we'd be willing to look at and be interested to look at for a local area coordination approach and thinking about that. But obviously also the UM service, I'll be contacting my colleagues and making sure we're involved in any of the groups taking the work forward, because we need to address the issues there.
Wonderful. Are there any other final comments or questions? Jane? You're muted, Jane.
I know. Yeah, sorry. Just one other thing. It was just in your presentation, it would be quite interesting if we could do a correlation between school exclusions and maybe BAME, and maybe that's something that we could do. I didn't see it, but there is a suggestion that BAME people are more excluded at school than others. So maybe there's just one other bit that we could do with the gangs. Yeah,
that's a really, really good idea.
Thank you, though.
Well, thank you very much, everyone, for a thorough debate. Thank you, Ian, for an excellent presentation. I think also going forward, we do have a economic vulnerability group that meets to discuss the issues of vulnerable young people going into this recession, and certainly becoming involved in gangs as a possible source of income is certainly an item on that agenda. So hopefully we can entice Ian to join us for our meeting in September.
Yes.
I'm taking Ian's silence as consent.
Sorry, no, I just say yes, that of course. Maybe you can hear. I'd be delighted to, James.
There we go. Okay, moving on. Item 6, adult mental health transformation update. I think Roger's going to introduce this, and then Maria's actually going to go through the substance of the paper, supported by Jane and Catherine. Roger?
Thank you, Chair. Yes, this is very much a team effort between the local authority and the CCG. You will recall that we brought a very significant report to the Health and Wellbeing Board around about 18 months ago, and the report then was endorsed by the Thurrock Cabinet, which was, I think, quite a significant overview and reshaping and remodelling of how we wanted our local mental health services to develop and go forward. So this report is an update on where we are, and I think you'll see that there's been some very significant improvements and some transformational initiatives. Others have maybe not taken as fast a pace as we would have liked, and COVID has clearly influenced that. The second part of the report talks about the experience of COVID and the lessons learnt from that. And I think, I'm sure we will come back to that at future times. And the third part of the report deals with the relationship in terms of the management of staff between the council and EPUT in terms of what the Section 75 agreement says and how we would like to take that coming forward. So I will come back and deal with the Section 75 part of the report in a couple of minutes, but I'm going to hand over now to, I think Maria's going to do the overview to talk about how much of the transformation programme has been advanced and where we need to do some more work. So with that introduction, I'm going to hand over to Maria.
Thank you, Roger. before I start, I just want to echo exactly what Roger's just said, in the fact that, you know, the production of this paper and the contents and the work that's gone into it really does reflect a joint effort. So it really is a partnership approach. I don't have a presentation deck of slides, so I'll just be talking to the report, just pulling out some key points. I will hand over to Jane shortly as well to give some updates. But just some key things I wanted to pull out from section 2 of this report. You know, what we've tried to do is write the report aligned to the kind of key themes that were identified, as Roger said, in the previous report, to show some progress that has been made. So, you know, one of the key things that came up before was that there was a real underdiagnosis of mental health problems within Thurrock. So we did some modelling previously, and there was 59.5% of the population who are likely to have depression that had actually been diagnosed. What we've done a number of sort of initiatives to try and broaden depression screening out within various partners, and examples of that are within the report. Within the last year, we think we've managed to close that gap slightly. So as of March, I think we've increased the sort of proportion of those likely to have depression who are diagnosed by 3%, which I think is positive to do that within a year. The protocol has been put in place in a few pilot GP surgeries within our Healthy Lifestyle service, and there are plans to broaden it out within sort of other agencies, sort of, you know, sheltered housing, for example, as well. We've done some work also trying to look at the quality of the information on GP systems, which I've mentioned in 2.5 of this report, really looking at kind of what the register, the GP registers look like. And there's been a piece of work undertaken to look at kind of the data at practice level, which there's a diagram of a profile card, sorry, which was produced by the Healthcare Public Health team for every practice, which sort of tried to show the relationship between sort of the issues of diagnosis and the impacts and what sort of individual practices might be able to do. And some of those conversations were really positive with practices, and there was a lot of interest in doing more things like the depression screening protocol. It's just with COVID, that's one of the things that has been sort of delayed with the wider rollout. The next sort of section just talks about some of the things that we have done so far under this kind of theme of improving access to treatment. So, you know, we have a programme called Stretched Quaff, which has, you know, looked to sort of increase the incentivisation available for treatment, and sort of the treatment of newly diagnosed depression patients is included within that. There's a number of things that Exclusion Thurrock have undertaken, which Jane will discuss shortly. And we've employed a mental health practitioner within the housing team in the council to really kind of upskill staff across the housing directorate and undertake specialist assessments there. Jane will also talk about the updates with the 24/7 crisis response as well. So I'll just skip through this and then come back to her. The next bit just talks about some of the work that's been done so far around sort of new models of care. One of the things we were quite conscious of was the focus on personality disorders within the previous report, and there has been a pilot put in place and some training that the council commissioned over the last year. We also, I think the report previously talked about open dialogue, and we did launch that. So we did the training and we launched that, but that was something that really was impacted by COVID. I think, just going back to what we were saying about partners, I would say that I think, integration and joint working with partners has improved during this. We've set up our mental health transformation board, and we've got good links into our Mid and South Essex board as well. I think, there was a long list in the report of transformation activities that were impacted on COVID. I've referenced some of them. I think it's important to state, though, that we have started to make plans to restart and reimagine some of these. I think Jane will reference some of those in a minute. But there's also a bigger piece of work that we plan to do, which is really looking at the impact of COVID on our local mental health, of the mental health of our local population. So taking into account what we're seeing nationally and locally, and looking to see what we think that might look like going forward in terms of demand. So that piece of work has started, and we've got quite a good sign up from colleagues to do that. The last section of the report talks about the remaining future priority work areas. There is a rather long list of priorities that we know we still need to work on. I think the work on addressing inequalities is going to be quite key, and then really bringing in some of the programmes that I've talked about at the start, but bringing them into the kind of wider transformation programmes that we've got going on. I think I'll hand over to Jane now to talk about some specifics, if that's all right.
Thank you, Maria. Thank you, Chair. We've got, I think I'll cover it in kind of like two areas. We've got what we're calling the system work, which is covering the urgent and emergency care mental health pathway. And as Maria mentioned, we launched our 24/7 mental health crisis response service on the 1st of April, which was quite an achievement, especially in the middle of COVID. And this has both a clinical and a non-clinical pathway. The non-clinical pathway has 3 sanctuaries aligned with it. One of the sanctuaries actually is based in Thurrock. The other one is in Braintree, and the other one in Southend. And the 3 actually work as a complement to the clinical pathway, where people and anybody can call when in a mental health crisis. Anybody can have access through 111, and you get the mental health option as option 2. And we've also got some dedicated lines which also feed into the crisis response team for the police, the ambulance, and other professionals as well, so that they don't necessarily have to go through 111 option 2. And the reason we have that is just to ensure that we can facilitate that element of making sure people are getting support as early as possible and as quickly as possible when in a crisis. So that service launched on the 1st of April. It has actually been pretty successful in gatekeeping and also supporting, diverting mental health kind of like activity from acute partners. And people are being supported actually in a very, very different way. And the feedback from those who've used the service, both from a service user perspective and from staff, that it has been very, very positive and very, very encouraging. So, of course, as part of this, we've built in a process evaluation, which we are always we are kind of like using all the learning to improve the pathways within that service. It interfaces very well with the statutory functions, for example, of the local authority around Mental Health Act assessments. And we are able to ensure that is covered quite well from a thorough perspective, Essex and Southend. So that's kind of like the downstream side of things. Now, Maria has talked around a number of things we are doing for transformation, both from a system perspective, but more so from a place perspective. So I'll speak about a place. So we've got our 4 primary care networks coming up, and we need to embed mental health within those primary care networks. Pre-COVID, we had already started that work, and we had progressed significantly. And this work was supported by a number of partners, including service users, to ensure that we developed a model that would work. Now, the model has 4 key functions. One, it looks at what the offer will look like within the PCN and how it will integrate with the physical health side of things, how it will bring together primary care, it will bring together social care, it will bring together the voluntary sector within the PCN, and the wraparound support to make sure that that team, that is a mental health team, actually is able to support people in a very holistic way. It also then looks at what the interface between primary care and secondary care will need to be. It's the seamlessness, because right now we've got a number of people whose needs are not complex enough to meet the thresholds of secondary care, but their needs are more complex than primary care can handle. So they kind of like get lost in this no man's land. And this model now will ensure that that does not actually happen, because we'll be looking at people based on need and what they require. And then we will look at, okay, fine, once we've managed the interface between primary and secondary care, what does the specialist end of secondary care now needs to look like? The people who've got very, very complex needs, how do we support them? Maria referenced that we've got a piece of work which we've done around personality disorders. This has actually been in response to some of the queries that have been raised in various committees in the system. And now we are moving into a second stage of implementing the personality disorders treatment for people who have significant complexities. The first pilot was actually very, very successful with very good outcomes, and we'll keep on monitoring that to ensure that any learning influences how we move forward. And as part of the primary care work, we want to make sure that we need to get rid of that kind of like creating gaps of multiple assessments for people who are accessing mental health services. But most importantly, when people have stepped down from secondary care, that we are able to wrap a package of care that helps them then no longer required to go back into secondary care. And also those who are starting to show signs of having a mental health problem, that we're supporting them a lot earlier so that their symptoms do not get to a point where they will require more specialist care. So we're looking at this both from a primary and secondary care kind of like prevention perspective, but also how to support people to build their resilience and their independence. And this has got to be in a very holistic way, making sure it's not just from a health perspective, but more from a system perspective. So unless there are other questions around that presentation, we'll always bring back, it's a very big program, and we have a plan around it, which we want to make sure will be presented at the Health and Wellbeing Board for updates on quite a frequent kind of like a basis. Thank you. Any questions?
James, can I just finish off on the section 75 and then open it up for questions? Is that all right?
Yes, please, Roger.
Yeah. So just to conclude the report, I just wanted to draw colleagues' attention to section 4.4 on page 145. Unfortunately, no one from EPUT doesn't appear to be on the call at the meeting today. We've had an arrangement with EPUT and its predecessor organisations for some years now under what's called a section 75 agreement, whereby we second our social care staff and delegate certain duties under the Care Act to EPUT. And that arrangement largely is based around the social care staff based at Grays Hall. That has worked well, I think, over the years. It's allowed us to have an integrated offer between health and social care. It's meant that we've been able to develop a single arrangement for how our community health offer, particularly around mental health. But we feel now that the time is right to have a fundamental review of that Section 75 arrangement. There are a number of options that are listed in the paper, including us transferring the staff over permanently to EPUT, maintaining the existing arrangements, or transferring the staff back more under direct management of the local authority. I think where we stand at the moment, I think the officer view is that we would want to strengthen our managerial oversight of our local mental health services. We think the joint arrangement with NELF in terms of having a senior manager appointment that covers both but accountable to both has worked well. So where we stand at the moment, our view is that we will not be renewing the Section 75 agreement come next March, but we want to look at a different arrangement whereby we can get a stronger voice for social care. We could look at integrating far more comprehensively the mental health staff within our transformation programme, the wellbeing teams, local area coordination, etc. But also, as I say, have a stronger managerial oversight about how mental health services are delivered at a local level within Thurrock. So I suppose it's just giving the board notice that as the DAS, I'm going to be writing to the Chief Executive of EPUT in the next few days to say that we are going to have this fundamental review of the Section 75 between now and the end of March, and highlighting what the various options that we're going to be looking at during that review. Thank you, Chair.
Thank you very much, Roger. I think if we start, I think I saw Ian Wake's hand up.
Thank you, Chair. It was just a comment to start with, and excuse me, then a question. Just in terms of the comment, if you think where we were 18 months ago and we'd had the peer review and all of the issues that were highlighted, and then I look or listen to what Maria and Jane have presented, I just think it's incredibly impressive in terms of depression diagnosis, which has rocketed in terms of case finding, the crisis care pathway, which was a real issue in terms of people in crisis not being able to get into the system quickly. The primary care holistic model, I know there's more work to do on it, but absolutely the right approach, and that seamless service and integrating with other community assets. If I think of IAPT and the amazing work they're doing on the trauma-based therapy, which again we didn't have previously, and the positive impact that's having, personality disorder, the early intervention psychosis work, I just think you should both feel really, really proud of yourselves. And I think we're very lucky as Thurrock to have you both. So thank you. There's an enormous progression in a really short space of time. My question was the same one I asked yesterday at the ICP. So the other thing, as you know, I'm really keen on, I know others are keen on, is the open dialogue approach. And we were part of a pilot that was paused. And I just wonder, maybe Maria, you can answer this, whether there's, when we know that might restart.
Thank you, Ian, for your kind words. Unfortunately, with your question, I'm not confident enough to give a formal answer to that without discussion with EPUT colleagues who aren't on this call, but I will find out and get back to you.
I just think we need to keep it on the agenda, is my plea.
Yeah, no, we haven't forgotten about it. And as we said in the paper, you know, it was a real success that we did manage to launch and do all the training and get us to that point. So I thought it was a real shame that it had to be pulled as part of it. But, you know, we also, you know, we'd signed up to the national trial as well, which was a big part of it. So I think it will depend on how those discussions go as well. But I will find out.
Thank you.
Okay, I can't see any other hands at the moment for questions or comments. So while people consider if they've got something they want to say, I'll just thank Maria for a brilliant report. I think it is terrific. I think some of the progress that we've made in Thurrock over the last two or so years, it makes me tremendously proud of the entire public health team. You know, it was only a couple of years ago that myself and Ian started talking about rolling out a online tool for schools to use that would have been about £100,000, and that scheme quickly became the school-based wellbeing team. 6 brand new members of staff, £1 million budget. So the get up and go that all partners have had has been terrific. In terms of EPUT and in terms of NELFT, they've been brilliant partners, and we're doing some tremendously impressive work with IMCs, with embedding mental health in primary care. However, certainly as a member, as portfolio holder for social care now, but formerly portfolio holder for education, I do have pretty significant concerns that whether it's a product of us being a small unitary in a part of quite a large organisational structure, there is not the integration that we always want to see in terms of social care. Roger's touched on that in terms of the Section 75 agreement. We do need to try and mesh a closer relationship managerially, both with the EPA adult service and more so also with UMS, to try and tilt that balance towards, as much as clinical treatment is welcome, the greater scope on intervention. I don't feel that we get that at the moment, and that's why I do fully support Roger in saying that perhaps renewing the Section 75 agreement next year isn't advisable. I know that Sheila Murphy is working very hard, having conversations currently with EPUT about how we closer bring that working relationship together, because certainly schools tell me that they don't feel that they're getting what they need. So I think a lot of very, very positive work has happened over the last 2 years, and I feel that this is a time for us to look at greater intervention, greater prevention, and that closer managerial link. Okay, I've seen a few hands go up. Councillor Mays, then Tanya.
Thank you, Chair. Thank you for the report. It was very, very good. Really positive to see and hear about the improvements made over the years, which is great. And I do think that with any service, you need to obviously aim further, so get better. And I think I'm very supportive of Roger's moves for the 75 agreement, just to effectively move things forward. Because if and this is why also we put forward the member-led board to be able to really sort of deep dive, give mental health the place it needs to have the full discussions, not necessarily just agenda points, but actually a full holistic view of it across the board. Obviously, working with everybody to get the best results. So it's really positive to hear it. I do echo a lot of what the chair has said, and I just think now's the time to sort of have a deeper look in what we're doing, especially as members, to help try and move things forward.
Tanya?
Yeah, so obviously when I come to the Health and Wellbeing Board, I represent NELFT, which is adults and children's, which include UMS. We have been meeting as a management team because UMS clearly hasn't got enough of a presence at some of these meetings. I think Jill Burns, who's my equivalent, will start to join. But they presented recently at the HOSC, I think it was, if I remember. One of the meetings Jill presented at. But we're certainly more than happy to come and update on UMS. And I know that Sheila and Jill are going to have a meeting to follow up from, it's the Thurrock Integrated Care Partnership. And we're going to make sure that we get those links much better. I think because it's commissioned externally across 7 of the Essex CCGs, there's not always that close connection, but we'll certainly make sure the links are there. But very little is actually escalated to senior management. So we just need to get that communication better so that the view of UMS is not felt by a lot of the management and they're not hearing it. So we need to just get that communication much better. And I know Sheila and Jill are going to try and do that.
Yeah, I would actually just respond to Tanya before I bring other people in. I think we've often cited the position that you have, Tanya, as an ideal model, because that link that we get between different organisations through having a post such as yours, it does more to break down silos than, frankly, any different form of management reorganisation. I mean, that's essentially why myself and Roger will be meeting Anne Radmore in a few weeks' time to advance that case with the CCG. How many joint appointments can we make between the NHS and local government, because that is generally helpful. And my comments regarding UMS, as I've said, NELFT are a very significant partner, a very, very good partner, as are ePut. However, when I have schools tell me we do not feel we get what we need from UMS, when I have my own directors tell me we do not feel that we have the level of sharing that we need, clearly we need a recalibration. So I think my view is that we need to be honest that we don't feel we are where we need to be at the moment. But I think all the base ingredients are there. On the inputs, it's a bit more straightforward because the Section 75 agreement does give Roger something quite meaty to target in terms of reform. And on the input side, I know there'll be further conversations, and I'm sure Sheila will keep us updated. Looking at other partners, Councillor Mays, your hand is still up. Don't know if it's meant to be. No, his hand is down. Right, any final comments on this item? Okay, all right, we'll move on to the recommendations, which you'll find just after page 133. To note the progress, to endorse the detailed next steps and establish a member-led body. That body will be chaired by Councillor Mays, just for board reference. Is everyone in agreement with recommendations A, B and C? I'm seeing no objections, so I'm taking that as unanimous. Move on to item 7, which is the outbreak control plan. This is going to be presented by Ian Wake.
Thank you, Chair. Board members will be pleased to know I won't go through the presentation that I have done previously, because I think most of you have seen it at least twice, maybe 3 times. So just in terms of high-level summary, outbreak control plans are required for every top-tier local authority and set out how we are going to manage the COVID epidemic moving forward. Ours was published on the 30th of June. There was a level of assurance through Public Health England and a new government agency called the Joint Biosecurity Centre. I think the feedback on ours was incredibly positive, and it was highlighted as one of the strongest they'd seen, which was really nice to hear. The purpose can be, I think, boiled down to 3 things. We need to know and understand what's happening with the epidemic locally. We need to prevent outbreaks from occurring. It's much better to prevent them than to try to deal with them when they do occur. But if they do occur, we need to identify them and rapidly respond to shut them down. The plan does a series of things. So it sets out the roles and responsibilities of all the key partners. It defines the governance arrangements, and our governance arrangements, they were kind of specified nationally. So we have a health protection board, which is an officer-led kind of clinical board that deals with the day-to-day implementation. And then we have a member engagement board, which provides strategic political oversight and scrutiny. So the Health Protection Board has met twice. It's meeting every fortnight. The member-led board, we had an informal meeting yesterday, and we will set up formal meetings that will happen every 6 weeks. The plan sets out a series of capabilities. So as the chair maybe not too kindly described the surveillance and intelligence cell as Big Brother, but its purpose is to really understand the data and what's happening with the epidemic. That actually meets daily, so we are looking at the data every single day. We are getting a lot more data than we used to get in terms of granularity, so we can now see individual cases and their postcodes, and that's mapped. We're looking at testing data. I'm pleased to say at the moment, so we have a threat level, which is set out in the plan. Our threat level is currently 0, which is the lowest, which is green, but I don't wish to sound in any way complacent. That may change, and we need to detect problems as early as possible. The plan sets out testing arrangements. It sets out comms and engagements, which I think is absolutely critical, and there is a separate communications and engagement plan that sits alongside the outbreak control plan. It sets out our local arrangements for NHS test and trace. Underneath the plan sits a series of very detailed protocols, and actually the work on the protocols is far more than the work on the plan itself. So we have dedicated protocols for care homes, for primary care, for workplaces, for vulnerable residents in residential settings, for example, sheltered housing, homeless hostels, for domiciliary care, for communities, and for schools and early years. So the care homes one is, well, we've had that since May, and I've just completed the refresh, and that's been sent out this week. The workplaces one is complete, the schools and early years one is complete, the accommodation residential settings is complete. The others are in development, but I will hope they will all be complete by the next Health Protection Board. We have 4 settings-based hubs that will oversee the implementation of the protocols, and we've used the existing TCG structure and Stronger Together and our care homes hub to run those. Test and Trace itself, I think, has a series of challenges. So we don't have access to what's called CTAS, which is the national database at the moment, which makes contact tracing really, really difficult. We did escalate this through the CCG yesterday. We have potentially yesterday identified a workaround, so we've received more data and different data sets that we can possibly link manually, and we can find a way of communicating what we're doing to what the other elements of the system are doing. We may be able to start contact tracing from next week. But again, that's not without its challenges, and we are working through that. The other paper that you've got, and I'll take them together because of time, if that's okay, was around governance. So that sets out what the the governance structure of the Health Protection Board and the Member Engagement Board and what their functions are. It sets out a more detail the relationship with the SCG and how we and the kind of wider NHS and how we communicate. So we have a weekly report through what's called the Common Operating Picture, the COP. So that goes to the SCG weekly. We would re-engage the SCG at level 3, so that's the highest threat level. If we get to level 3, we're into second wave territory and potentially local lockdowns. And I think if you have a local lockdown, the SCG has got to manage the response for 2 reasons. Firstly, there are going to be people who maybe work inside the geography of the lockdown and live outside of it. So it affects a wider geography than just Thurrock. And secondly, obviously, you've got a high risk of transmission spread outside of the lockdown area. The paper also discusses enforcement powers that came down to local authorities as of last Saturday morning. The powers sit with the DPH Chief Exec or the Head of Environmental Health, and they allow us to close individual settings or public spaces. Wider powers in terms of local lockdown or restricting population movement or closing transport don't sit with the local authority. They are retained by ministers. And if we wanted a local lockdown, the governance route to achieve that would be, I think, to be the route to be proposed by the Health Protection Board and have agreed then through me to the Regional Director of Public Health and up to national. Plus, as I say, escalation back up to the SCG. I'll stop there and have to take questions.
Thank you very much, Ian. Have colleagues got questions or comments they wish to make? Okay, I think for the first member oversight board meeting that's now being arranged, we are going to be considering the response of Essex County Council to the small spike that we've seen in the north of the county. So at least we'll have an opportunity to consider them as a test case and consider how their procedures have worked out to try and refine our own approach on essentially a dry run. Well, if there are no other comments on this item, Ian, thank you very much. I don't think we've got full recommendations, have we? Oh, yes, we have. Recommendation A that outlines the governance arrangements. Recommendation B outlines the threat level, escalation criteria, and recommendation C to note the enforcement powers available to the council through the Director of Public Health. All members in agreement with those recommendations?
Yes.
Thank you very much. Item 8 is the Health and Wellbeing Strategy Refresh, a new approach in the post-COVID world. That's going to be introduced by Darren and then supported by Roger and Ian.
Brilliant, thank you very much, Councillor Alden. I've got a PowerPoint which I'll whiz through very quickly because I'm conscious that many board members are already aware of most of this stuff, because I've met with quite a few of them along the way. So I'll just whiz through this, Councillor Alden. You've got a report in your papers which I'll reference later as well. I thought it would be important to put up the first slide, which is just reinforcing that Thurrock's Health and Wellbeing Board is actually a statutory partnership function, and one of the key responsibilities of the board, as many of the board members know, is to develop and oversee the implementation of an health and wellbeing strategy for the area. You'd be keen to see that even the board is not a static organisation, so we've recently over this year had Her Majesty's Prison and Probation Service join us, and depending on the final priorities in the refresh strategy, we might want to consider, or members might want to consider, extending that further, for example, to DWP colleagues and partners. So the Health and Wellbeing Strategy was launched in 2016. It's a 5-year strategy that focuses on the wider determinants of health and wellbeing. It was developed by a public health team, Tim L. Sutton primarily, who held the ring last time round, and it was subject to substantial consultation with system partners and members of the public, which helped to define what the framework is in the current strategy and the current priorities. It captures action taken by Thurrock Council and key partners that impact on people's physical and emotional well-being. And it's a live organic document that has been updated to reflect policy developments and emerging challenges, ensuring it has remained fit for purpose up until now. So I'll just give it a little bit of what we've done to date to get to this point. So we've adopted broad project management principles to scope the refresh. We've identified the broad approach and got some plans that sit behind that. We've identified the key deliverables and key milestones. We've considered emerging evidence provided through JSNAs. Sorry, you can't see the presentation, can you? Sorry about that. Thanks, Roger. So I won't start the presentation again, but I'll share it again now. So I'll just skim through those ones that I've just talked about. So this is some of the evidence that we've looked at along the way as part of trying to identify what the framework might look like in future, what the potential priorities might be. So as you can see, we've done quite a lot of work at looking at some of the JSNAs that public health are considered, as well as wider documents that cross partner boundaries, as well as local authority key strategic documents. We've met with some key system partners today over the last couple of months, just to reflect the range of interests across the council beyond. So as you can see, we've engaged Thurrock CBS, public health colleagues, adult and children's social care, children and adult education, housing, place regeneration, economic development, adult safeguarding and community safety, CCG colleagues, and with various council senior management teams across the council. We've received some feedback on key themes from some of those system partners. So there seems to be general agreement that the refresh strategy should continue to focus on the wider determinants of health, but particularly around the impact of housing, safety and feeling safe, economic development and regeneration on health and wellbeing. Governance process in the refreshed health and wellbeing strategy should be strengthened and building on existing governance arrangements. So one of the papers being considered by board today is the creation of the Thurrock Integrated Care Partnership. It would be proposed that a number of the priorities would be overseen by that, which would then report into the board, depending on the members' decision on creating the Thurrock Integrated Care Partnership. The strategy should be embedded into the day-to-day work of system partners and not seen as an additional piece of work or a bolt-on. One of the ways we're thinking of doing that within the council is to include the health and wellbeing strategy priorities within service plans across the business. The strategy should reflect lessons learned from COVID-19. They're the positive lessons as well as any challenges that we've experienced. Resources should be identified to ensure the strategy remains on system partner radars, and effective oversight can be provided, which helps to drive forward the strategy. So as members know, we usually provide an annual report. It'd be good to actually, the strategy is owned by the partnership. It's driven forward by the partnership, so it'd be good for the partnership to consider what kind of resource we might want to drive it forward post 2021 July. Many of the existing priorities, which you won't be surprised to hear, should remain in the refresh strategy, and the draft strategy framework that we've developed, which I'll come on to shortly, has been widely welcomed by people who've engaged so far. I'll put this slide up. This is the current strategy framework. And as you can see, I've just put this slide up so you can see where we've made amendments. So the healthier, safer and accessible environments domain goal started off as healthier environments. But working with public health and colleagues, we've identified that it's good to put equipment in park and create cycle paths, things like that, to enable people to remain active, but as long as they feel safe doing so. And 3D, first of all, focused on the identification of depression, but as identified by Maria's and Jane's presentation just now, we've done lots of work on wider mental health challenges, so we changed that objective. This is the new domain that we're proposing, the new framework. The first 4 domains are primarily reflecting the current and existing domains. If it's not broke, there's no need to fix it. It's the last 2 domains, domain 5 and domain 6, will pick up on the wider determinants of health and enable us to provide a little bit more focus on housing and the environment and how that affects health and well-being, and community safety, which picks up on stuff like the gangs-related work that Ian's just focused on. Just so you know, the colour code in here, the blue ones are the existing current strategy objectives, and the orange ones are the ones that have been proposed as potentially new objectives. As you can see, we could end up with a plethora of objectives. This is just from meeting a limited number of system partners. So what we're going to have to do is consider how we rationalise the potential priorities that we come up with. So Ian's come up with quite a lot of this, actually. These are Ian's suggestions primarily. But we also want to include, as well as focusing on health data and health aspects, we do want to focus on the wider social determinants of health and tackling inequalities. This would reflect the 10-year review of Marmot, so considering stuff like homelessness, poverty, quality of homes. The proposed priority is a topic that requires action from multiple stakeholders. That means that the board can have a real genuine impact on influencing the direction of travel going forward. The proposed priority is an absolute health need, which is an issue that impacts on the health and well-being of a large proportion of Thurrock residents. Or it could be a relative health need, which is an issue where Thurrock is an outlier compared to England, for example, smoking prevalence. The proposed priority can be both an absolute or relative health need, and many issues in Thurrock are both, such as cancer, children's mental health that we've considered earlier today. A JSNA product has highlighted a need and made recommendations for actions, and we can pick up on the actions that have not been completed to date, because the health and wellbeing strategies, as we know, should be informed by JSNA programme, and it's not business as usual. We also wanted to pick up on some of the lessons learned, and there's been a reset and recovery piece of work been done that has been considering the impact and how we move forward out of the COVID pandemic. So we wanted to ensure the strategy reflects this stuff. So coherent shared vision, the refreshed strategy will reinforce the shared vision for the people of Thurrock that is informed by the people of Thurrock and endorsed by system partners at system, place and locality levels. We want to move towards outcomes and not outputs. The refreshed health and wellbeing strategy outcome framework will reflect a shift to outcome-based measures, while recognising that some KPIs will include outputs. So, for example, the fantastic work of local area coordinators already has output data in terms of how many people they want to engage, and what we want to do is add some qualitative measures so they're outcome based. The importance of technology will be reflected in the refreshed health and wellbeing strategy, and it will consider our future operating models and therefore outcomes may be impacted on by technological advancements and developments. It will also be important, however, to ensure that any challenges that may be created by technological advancements are identified and addressed. Collaboration through strong trust-based partnership arrangements. The health and wellbeing strategy will reflect partnership and governance arrangements that have been agreed across the wider health and care system and within and across Thurrock, reflecting the changing NHS landscape and the creation of the Mid-South Essex Health and Care Partnership. And at the same time, the refreshed strategy will identify health and well priorities for the population of Thurrock over 5 years, many of which will be joint partnership priorities. And finally, asset-based and strength-based approaches. The refreshed health and wellbeing strategy will build on the success of the TCCA and the work that the CVS has done in driving forward responses to COVID and engaging on members of the public. I'll just go slightly back to the previous one. So next steps, which are proposed in your paper, that's within members' papers, is being considered today by board, and we welcome your comments. We're currently creating a narrative, so it's great to have a framework, which you've just seen on previous slides, but we need to actually, before we go out to consultation, really understand what we mean when we're saying what are the priorities and what the framework actually means. So it's actually user-friendly to members of the public and wider partners. We're proposing on setting up a task and finish group, which is within one of the recommendations, which I'll put to on the next slide. The role of the task and finish group will be to finalise the refresh health and wellbeing strategy framework and establish the potential priorities that we'll go out to further consultation on. It will be considering and refining the proposed governance structure for providing oversight and reporting progress against all of the individual priorities to the board. It will be creating a communication activity plan to underpin the communication strategy that's included within your bundle of papers. And it will also support us to develop the necessary materials to go out to wider consultation. It will support the delivery of the public consultation exercise, and it would lead to development of the refresh strategy, which reflects feedback from the people of Thurrock following the consultation exercise. We were considering about opportunities for people of Thurrock to co-produce strategy proposals, and we're still continuing to do that. It's a bit of a challenge at the moment because many of the forums due to COVID are not operational and are recommencing. So we'll plan that into the timescales in due course, and we plan to go out to public consultation in early 2021. And these are the recommendations that are for board members to consider, which we hope that you agree with and approve, which are in your papers. Hopefully that's all right, Councillor Alden, and sorry for not sharing it in the first instance.
Thank you, Darren. Councillor Alden has just gone, I don't know if he's back on the call yet, but he's had to go and get another lead for his laptop, I think, because it's died on him. So I'll just briefly take over the chairing. So thank you very much for that, Darren. I don't know if Ian, if you wanted to add anything at all.
I think Darren's probably covered it. That was pretty comprehensive. I think the only thing I would add is that this is from personal experience, a completely thankless task to try and develop these, because everyone's got strong opinions about what they do and don't want in it. So just my thanks to Darren. I think you've done a great job so far.
I endorse that, Dan. Thank you for taking it to this stage, but at a time when obviously a lot of people are being pulled in many different directions with COVID response and will do for some time to come. Just a couple of words from me. I do want to emphasise how significant this plan and document is. It's one of the few documents that we are required to produce as a partnership, and it does set, if you like, the framework for how we are going to be developing our people-based services over the next 3 to 5 years. And I think the last document and the process of putting it together, as much as the document itself, was very significant, because it was the first document we produced since public health came into the local authority, and it actually, I think, brought parts of the local authority into the wider health and wellbeing agenda. So colleagues in planning, colleagues in housing, who most probably didn't see how they fitted into that wider health and wellbeing arena. But I think it's brought parts of the council certainly into the health and wellbeing agenda where they hadn't perhaps been so much before. It is also, I think, as much about not the document itself, but it's the process of putting the document together. So it's very much about the hearts and minds and convincing people. So it has to be very much a co-produced document, both within the council, with partners, but also with the community. So I think really want to emphasise it's not just about adult social care, it's not just about the council, but it is very much about a whole system and co-produced production at the end of the day. So any other comments? Can't see that James is back on the call yet, so I'll continue to chair it for a little while then if colleagues are okay. Anyone want to, no hands are showing at the moment.
Roger, can I just give a special thanks to a member of my team, Claire, because without her I would not have got as far as I've got today, and I do appreciate the plaudits, but to be honest, without Claire's support, I just wouldn't have been where I am. So I just wanted to acknowledge that to the board.
Thank you very much.
Thanks.
Yes.
Cheers, Roger.
Thanks, Darren. That was much appreciated.
Thank you.
You stole my PA. I'll forgive you for that, Darren. Okay, so I'm not seeing any more hands showing. So the 3 recommendations are to agree the approach, set up a small. Who's on the task and finish group, Darren? Who needs to be on that?
We've got a few recommendations. Ian's provided some. We've got some recommendations across the business. We've got a couple of gaps. So over the next week or so, I'll finalise the potential task and finish group and liaise with yourself and Ian and colleagues to finalise the membership and the terms of reference.
Brilliant. Okay. Thank you very much. So I think I can't see any dissent. So I think we're quite happy with the recommendations there. So thank you very much for that, Darren. So I can't see James on the call yet. So he's obviously, hope he hasn't gone out to buy one on Amazon or something. I don't know where he's gone to get this plug from. So let's go on to the next item. We've done the agenda, which is the Mid and South Essex Health and Care Partnership Memorandum of Understanding. So can I thank Jo Cripps, who I think is still on the call, for her perseverance. We most probably should have put this slightly higher up on the agenda, but hopefully you get a feel of some of the other items that we're discussing at the Health and Wellbeing Board, Jo. So this has been an item that we've been discussing for some time, and I know Ian was very instrumental in some of the early work around this. So can I hand over to you, Jo, just to sort of introduce it? Thank you.
Yeah, sure. Thanks, Roger. And helpfully a helicopter's just going over my house, which is not very helpful, just as you're going to talk. So you've got the partnership MOU in front of you. This is a piece of work that's been developing over several months and something that the partnership felt it needed to kind of, I suppose, settle some of the concerns and the issues that we've had around partners working together and what the partnership is and what it's not. So the MOU was kind of put together to, I suppose, solidify and codify how we're going to work together. It was built on some work that was done in Yorkshire and very much built on the work that Ian did locally with Thurrock Health and Wellbeing Board around that memorandum of understanding, and you'll recognise the Venn diagram at the back of the document as being one that you've probably seen Ian present before. The MOU is built on a number of principles, primarily that subsidiarity is absolutely key in our partnership working. Our partnership comes together to make collective decisions for the benefit of our population, but those decisions and the impact of those decisions is felt locally, and that's where the focus of our work needs to be. So very much supporting Thurrock in this case as its partnership, and acting as a servant of the people that we all serve. We've recognises also the critical role of the health and wellbeing boards and the HOSCs in terms of their support for the work and scrutiny of it. The MOU isn't a legal document. it has no legal bearing whatsoever. It also doesn't override or replace or duplicate any of the statutory functions of the organisations that make up the partnership. So very much it is a document that describes how we want to work together and the principles upon which we'll work. So it's a really, I think, a great step forward for our partnership, because this is something that we've been kind of building up to, I think, and as we develop into an integrated care system, this will be a key kind of seminal document, if you like, that describes how we're going to work. The Partnership Board approved the MOU in June, and it's doing the rounds through all of the governance processes of our partner organisation. So it's presented to the Health and Wellbeing Board for approval. I think I'll stop there, Roger, and I'm happy to answer any questions, but I guess that's the kind of bare bones of it.
Thank you, Jo. I notice Mac is on the call. Thank you for attending the meeting. I wondered if you wanted to say anything at all, Mac, at this point.
That's very kind, Roger. I thoroughly enjoyed listening in to everything from Ian's presentation on violence all the way through. Jo's covered all of this paper. What I like about it is it together with the paper on Thurrock Integrated Care Partnership, it clears the way for any space that is left if there are any changes to the formal structures around the CCG. It puts the partnership right at the centre of everything we do together and place at the forefront of all the policy development. So I think this is just another brick in the wall to strengthen place in the way that we're all trying to do.
Thanks, Mac. I've got Ian, your hand is up.
Thank you. Perhaps unsurprisingly, I also welcome it. I was obviously instrumental in writing quite a lot of it. I think it reflects really well what we'd already agreed in Thurrock, so that's really great. And I really hope it will try and put to bed some of the tensions that have been in the system in terms of what sits at place level and what sits at Thurrock level. I think we need to continue to hold people to account for it, because I think that inherent tension still exists, and I think it's been apparent during COVID. I often hear the phrase, we need a unified approach to this across the system, and I'm generally quite sceptical about that. We don't have uniformity of needs, and I think we need a variety of different approaches. I think subsidiarity isn't the only principle as well, which is really important. So there's very much the strengths-based approach and that bottom-up approach, and working with communities and community assets and third sector is really highlighted in terms of some of the other principles. So I think we need to continue to keep that in mind. I think where you bring a range of partners together, you will always get tension. The NHS tends to operate, as we know, on a very top-down model, and I don't think that's going to change. But hopefully this MOU will be one way that we can manage that and manage the relationship successfully.
Thank you. I think James is back online now, so I'm going to hand back to you, James. Okay.
Thanks, Roger. I do apologise for Darren. I enjoyed 9/10 of his excellent presentation. In terms of the MOU, I think it's tremendous irritation to everyone involved how long it has taken to get to this stage. So I don't underestimate the work that Jo has had to put in. So Jo is greatly appreciated, as is the excellent support you give to the wider partnership board. And I really welcome the leadership that Mac has provided along with Professor Thorne. The phrase that place it should be the primary planning area is the phrase in the MOU that I think I'm going to have put on a mug and maybe a couple of t-shirts, and at some stage I will tattoo it on wider colleagues when they're not looking. Going forward, I think that one thing that COVID has taught us is that there are certain things that needn't take as long as they take at times. So it would be very, very helpful to actually, when we have this summit, and I know Jo is working quite hard with Roger on an agenda for a summit for the reshape work, it will be helpful to actually nail down the exact reasons that we have been able to use COVID as an excuse for expediting certain work, because certainly in terms of getting the MOU over the line, all that work none of it has come from the easements we've had in the Care Act, for example. A lot of the positive work we've done in terms of discharges from hospital haven't come from easements from the Care Act. So I think it's quite clear that as we move forward as a partnership, guided by this memorandum, there is a huge amount of work that we don't require emergency COVID powers to use to expedite certain transformation. And then finally, the only thing I'd just like people to bear in mind is, as I've already said, we have got a conversation coming up with Anne Radmore about can we have jointly appointed posts between the CCG and the council. We can't lose the voice of children in this. Children's services is utterly essential. I think every council in Essex has got an overspent dedicated school grant to the tune of millions upon millions. This is largely due to the pressure of education and healthcare plans. If we had a weakened relationship with our CCG, that cost burden would grow exponentially. So I think it's very, very important that as we look at how we can better protect that coterminous relationship between CCG and local authority, we do it from the basis of this isn't just adult services and adult social care. Children's social care is a vital point of this. And if that relationship, if we can't find a way forward with Anne and cement that local government CCG relationship, the commissioning framework, which is already difficult and already cumbersome and already slow, that will become worse. And economies of scale are not something that affects this. It's only the ability to be flight of foot when signing off these plans, when monitoring the quality of these plans for the outcome of children. So that's kind of my big ask, that as we take this memorandum forward, we use it as a starting point, not an end point. And hopefully the next important destination along that road will be a conversation regarding the type of relationship between the councils and CCG that frankly we have with Tanya, sitting between us and Nelft.
Yeah, thank you, Chair. And I agree. I think it's it's to build from. It's not the end point. And I think, and Ian's right, we need to kind of hold ourselves to account against the principles that we've adopted in the MOU as we move forward.
Any final comments, colleagues? Okay, brilliant. Well, after what's been a torturous period, recommendation A, to approve the Memorandum of Understanding. Are we all agreed?
Agreed.
Fantastic. I would have turned borderline violent if someone said no. Right, item 10, creation of the Thurrock Integrated Care Partnership. Roger, I think you're down to introduce.
Right, thank you, Chair.
Roger.
Yeah, no, I'm just getting the paper. Too many buttons to press and things to click. Thank you, Chair. This follows on very neatly from the previous item, and we just wanted to describe for you how we are building the partnership at a local level, fitting very neatly underneath the MOU, which we've just agreed. So for some time, I think it was previously known as the Alliance locally, which is the officer group which brings together the CCG, the local authority, our provider organisations, which is now the Mid and South Essex Hospital Group, EPUT, Nelft, Healthwatch, and our community as well, and represented through the CBS. So this is the officer group that is overseeing a lot of the place-based work that we're doing. And I think what we want this to do is to develop further. It's obviously already had some very successful initiatives that are detailed in 2.2 around the development of the Better Care Fund. It has been the engine that's been driving all the work around the integrated medical centres. It has developed, obviously, the joint appointment arrangements with Nelft. We've done a lot of work around putting pushing ahead with our transformation programme around social prescribing, around the enhanced primary care teams, overseeing the development of local area coordination and all the work around the development of our sort of transformation programme at a local level and the wellbeing teams. So all of this has been overseen previously by the what was then previously the Thurrock Alliance, which we're now moving into a formal integrated care partnership. So I think we want to take that further. We would want to see us working more as a local system. Some of those schemes are still very much in the early development, as we know, around the integrated medical centres. We want to develop the BCF into a wider pooled fund. And now I think we all recognise that it's very much had an adult's flavour to it. And Sheila and colleagues from the CCG on children's now are very much part of that, the TICP, and we want to have a stronger focus on children going forward. So I didn't want to most probably say anything more than that, Chair, but it's just to note that this is now if you like, the place-based structure. Other areas clearly will have their own arrangements, but this mirrors quite well what is happening in the other places across Mid and South Essex. We see this as being very much the engine room for the development of our ideas across health and wellbeing locally. So it's asking for the board's endorsement, and we'll obviously be reporting back to the Health and Wellbeing Board on a regular basis.
Thank you very much, Roger. Has anyone got any comments on this item? It's almost a shame, Roger, that we're not kicking off a 2-year process to write a memorandum of understanding. Now we don't have anything to do.
I think it's more to do with exhaustion after 2 hours of a meeting, Chair.
If we don't have any further comments on this item, move recommendations. Any objections? Wonderful. Moving on to initial healthcare assessments. Sheila, are you presenting or is Janet?
I am. It's Janet Simon.
Janet's there.
Morning. So obviously the report's been sent to everybody, so you've seen the report. So this sets out what the local authority and health are doing in partnership to meet the needs of our looked after children in terms of initial health assessments. So when Ofsted visited us in November, one of the areas that they identified need to improve was the timeliness of initial health assessments when children come into care. So obviously I'm not going to go through the whole report, just to say that we have a duty to make sure children have health assessments, that we're aware of their health needs, and that we're meeting them. And so this report really is for members of this board to have a look at and to consider the recommendation for setting a timeliness at 90% in terms of initial health assessment. So there are 2 measures here. So the first measure is for the local authority, when children come into care, to make a referral to our health colleagues within 5 working days. And then for health colleagues to complete the initial health assessment within 20 working days. We report a month in arrears, and the reason we do that is because we can't count the initial health assessment as complete until we get the paperwork back from health. So we're acutely aware that if we count it, if we report month on month live, then it's going to be almost impossible for health to meet that target. There's also a brief report from health, and I don't know if there's anybody there who wants to speak on that, because I understand that health are experiencing some problems in terms of being able to make sure that the health assessment's done in a timely way.
If no one else wants to respond, I can just respond on Nel's behalf, just to say that a number of staff were redeployed due to COVID. We're now getting those staff back, but this is absolutely a high priority, and any breaches are being looked at weekly or daily, even with the assistant director and colleagues. So this is the priority, and I understand performance has got back now and we haven't got any breaches currently, and we'll continue to prioritise this although there are some still some staff who are out on redeployment, this is something we'll aim to prioritise so it isn't affected.
Thank you very much, Tanya. Have other colleagues got comments or questions? Sheila, was there anything you wanted to add?
I think I just want to add that, this was an Ofsted recommendation, and I know it's health and ourselves are working really hard to make this happen. It's really critical for looked after children to have those initial health assessments in a timely way, so that when they come into our care, if they have got any, at that point, unidentified health needs, we can pick them up quickly and work on them. So whilst I understand that people have been drafted over to doing other things during COVID, obviously, if for the looked after child, if they've had a delay in having an initial health assessment, that might have a longer term impact for them. So whilst accepting that this is what's happened in COVID, the sooner we can get that back. And as you say, Tanya, that we've now not got any breaches, well, that's good news.
Thank you, Sheila. Any other comments, colleagues? I think this conversation actually highlights the importance of roles like Tanya's. If I can just wave the flag again for co-mingling of staff and integration, it does give children's services a very tangible, very direct link with health services. So often health services are preoccupied with the adult social care of life or with the acute hospital side of life, but certainly local authority finance directors would say that children's services is one of the greatest concerns, and certainly those of us in children's certainly be saying that the welfare of young people and these assessments are our greatest priority. So roles like Tanya's, again, continue to prove the importance of these jointly appointed posts and these shared responsibilities. Sheila, I think you wanted a update on initial health assessments again for the next board meeting, so we can see it progressing. Is that right? Yeah, very good. I think that's on our draft work plan.
Yeah, I think, given it was highlighted in an inspection, I think the board needs to just keep sight of this recommendation, to make sure that we are still delivering as we should be. It can be just an information item if it's all going as it should be.
That's a good idea. Jane, did you want to come in?
Yes, please. Just to say, welcome the opportunity to bring obviously initial health assessments to here. Initial health assessments sit as a corporate responsibility of the CCG, and the review health assessments is part of the local authority, so we do need to work in partnership. There are a couple of things that are perhaps new initiatives that we're looking for the initial health assessments. So one, we've taken to region to see whether we could perhaps extend a nurse's role supervised by a paediatrician to do the initial health assessments. Nurses have done many extended roles over the years, and the role of initial health assessments for looked after children could be completed by a nurse. It just needs to it needs a change in the legal status. So that's been looked at by Ruth May and her national team, which might mean that we have better success at maybe some of the deliveries. And the other thing is that across Pan Essex, because our children are placed in Pan Essex and outside, we're doing a piece of work around capacity with the paediatricians and seeing if that is the best model and if there is something else that we can do. So we can bring something back maybe to next board as well, and we'll do it in partnership, which would be great.
That's extremely helpful, Jane. Can I just ask on the recommendation, perhaps a question for Sheila? We've been asked to agree a KPI of 90% be established in this regard and progress reported to the board. Is there a statutory target we should be hitting? So is that 90% a stretch target, or what does that represent for us?
Sorry. I'm not sure there's a national target as such, because the expectation would be that all looked after children who come into care have their initial medicals in a timely way. So we've been given the timescales. So those timescales that Janet mentioned, they're the statutory requirements, which is altogether 25 working days. So I would imagine that the legislation would have an expectation that we met that. 90%, I would say, is a stretch target, because we have been as low as 30% previously when Ofsted came in. So the improvements we've made now are good improvements, and putting 90% down would really keep us focused on making sure that those health assessments happen in a timely way.
You want to back in? Do your hand pop up?
No, I'm trying to switch it off.
Okie dokie. Well, perhaps when we have, well, probably not for the next board meeting, but certainly when we have our first board meeting of 2021, I think that would be a good opportunity to consider that 90%. Consider where we stand. Is that adequate? Is that a realistic target given resource, and is it an adequate stretch? Well, if people haven't got any further comments, happy to move recommendations A and B. Everyone agreed? Thank you very much. Work programme, Darren?
Hi, Council Warden. Yeah, there's a work programme included in members' papers, and what we're quite keen to do is to encourage wider members to just consider the work programme offline, perhaps provide any kind of feedback to me on potential agenda items, because what we want to do is ensure that all agenda items sort of meet the needs of all partners, and that helps to ensure that the Health and Wellbeing Board remains active and of interest to all wider partners. So we just encourage people to submit proposed agenda items, which we'd give to you as the Chair, Council Warden, to consider. And we're setting up the next meetings, which are on the forward planner, and we'll confirm that with members.
Thank you very much. I think you might have covered this when I was temporarily out of the meeting. I think it would be helpful to see a draft work programme for the task and finish group on the health and wellbeing strategy, so different departments and different partners can start to consider what their resourcing level will be for the work and when we expect them to come forward. Are we in a position maybe sometime in the next month to bring forward a work programme for the task and finish group, Darren?
We will be. We've got some detailed timelines for the health and wellbeing strategy refresh anyway. We know the elements that we've got to take to get out to consultation in early 2021 is when we're aiming to go, Councillor Alden. So as I develop the terms of reference and the membership for the task and finish group over the next week, we'll seek approval from colleagues on that. And from that, we'll use our project management principles to identify what key deliverables are and the timescales and resources.
Excellent, thank you. Right then, I know that Tanya has asked for an AOB.
Yeah, just wanted to give a nice positive story. So the Better Care Together, which is the adult transformation programme, has been shortlisted for the Health Services Journal for system transformation and service transformation. And we'll find out on the 4th of September. It's virtual, there's no big do, but that you can join virtually and they'll go through all of the feedback from the panel. But there's really good recognition, so I'll let people know at the next time and share. But yeah, it's been seen as shortlisted across the country, so really positive news.
That's really terrific news. I know that we are also shortlisted for Council of the Year. That too will be a virtual ceremony. But I certainly think if we win this one on the 4th of September, did you say, Tanya?
Yeah, 4th of September is where we can all join from our laptops and watch it, find out if we won.
Well, if we're successful, I'm sure at some stage, Roger, we can arrange cake and bits and pieces in the chamber. If we are not successful, I'm sure Roger can arrange chips maybe on. Any final comments, colleagues? No. Right, everybody, thank you very much for a meeting that is only overrun by 9 minutes. And I a very nice day in this scorching weather. Thank you very much.
Bye.
Thank you.
Thank you.